My name is Margaret Hayden. Welcome to Medical Center Hour. I'm a primary care doctor here and faculty at the Center for Health, Humanities, and Ethics. I'm so excited today to be bringing Dr. Jim O'Connell here, who will be giving a speech, as you see, Continuity Within Chaos, Caring for Individuals Living Chronically in Shelters and on the Streets. Before I introduce Dr. O'Connell, some brief housekeeping and CME info. For those of you who are interested, you can get CME credit from this lecture. This is the key code for today, 27597. If you can text it as you see, and if you need any help with the system or haven't used it for the first time, you can feel free to email Charlene Kaufman here. A couple other logistics. For those of you on Zoom, we'll have some time for Q&A after the event. You can use the Q&A feature on the Zoom, and we'll be moderating that. For those of you in the room, we'd love to have questions. Will be a microphone, and you can also use the mics on the table. Okay, on to the main event. I'm going to go back to the slide for now. So today we're really excited to be hosting a personal hero of mine and role model, Dr. Jim O'Connell, the president of Boston Healthcare for the Homeless Program. Medical Center Hour is proud to be partnering with the UVA School of Medicine AOA chapter to be bringing Dr. O'Connell here as a visiting professor. As the founding physician of Boston Healthcare for the Homeless Program, Dr. O'Connell began full-time clinical work with the homeless in 1985. He established the nation's first medical respite program with 25 beds nested within the Shattuck Shelter in Boston. Since then, Boston Healthcare for the Homeless Program has grown and now has a staff of nearly 600 and cares for over 10,000 people a year across 30 clinical sites in the city of Boston. And it's a model for homeless healthcare organizations across the country. Dr. O'Connell is the author of a book, Stories from the Shadows, Reflections of a Street Doctor, and the subject of Tracy Kidder's 2024 best-selling book, Rough Sleepers, Dr. Jim O'Connell's Urgent Mission to Bring Healing to Homeless People. I first came across Dr. O'Connell in Boston Healthcare for the Homeless Program as a 17-year-old when I volunteered there as a high school student. It was a transformational experience that solidified my own interest in medicine. As a teenager, I was in awe of how Dr. O'Connell and his organization centered human dignity and respect in every aspect of their work. And I thought at that time, this is exactly the type of doctor and the person I want to be. I still feel that way now. We're so happy to have Dr. O'Connell here.
Thank you very much, Margaret, and thank all of you for being here. I was telling Margaret and Sanjay when I was with them last night, it's my first time I've ever been at UVA, first time I've ever been in Charlottesville. So it's a treat to be here, although I wish you could have warmed it up a little bit for me. You're about the same temperature as Boston now. So let me launch into this because I'd love to get to wherever the questions are, and I should do slideshow, but I don't know how to do that. So I would love to just share with you a little bit of the experience, because just to be honest, this is not what I meant to do. You know, I was trying to do something else. And, you know, be careful that the accidents along the way push you in a direction you never thought you'd go. So I got into homelessness, never knowing anything about it or not knowing anything about it and having to learn the hard way. But when I first started, I promised the people that put us together that I'd show a slide like this when I started, because I was finishing residency, took on this job a little bit by conscription rather than desire, and I was going to do it for a year. But what I didn't know was that the grant that had been given to the city of Boston to take care of homeless people back in 1984 and 85, the foundation, the Robert Wood Johnson Foundation, which had given the mayor the money, demanded that he has to work with homeless people to decide how they wanted to be served. I'm still a resident, so I didn't have anything to do with this. But this is kind of a later iteration of our consumer advisory board, and we've been trying to find a better like patient advocacy board. But several of these folks are also on our board of directors. So they insisted from the beginning that they had to be part of the design, the implementation, and the governance of the program, which was not something I had been used to coming out of the hospital. And so I show you what they got together at City Hall with the mayor over a year, and this is in 1984, and they came up with this as what they wanted, and the things I'll tell you about our program come from what they wrote down here. And then they had a legal firm make the mayor and the chiefs of medicine sign on to doing this. So they wanted continuity of care. So homeless people in Boston back in that time, and I would argue till this day, want most of all something that isn't fragmented. They want continuity, the same way as they would say we would want in our own primary care and specialty care, whatever it is. You want the same people to take care of you so you don't have to constantly reframe that. And I'll never forget them saying their lives were full of so much loss and fragmentation. The last thing they wanted in their healthcare system was a fragmented system. So that was the thing. And the way they hedged the bet is they made us work in teams. So I've never, as in my 40 years of doing this work, never had my own panel of patients. I've always worked with a nurse practitioner, physician assistant, and social worker, and we share equally in the care of our patients. And I thought that was kind of a brilliant early thing of making us work in teams, but it had nothing to do with that. It was all about continuity of care, because they hated, and I wasn't ready for this, they hated people like me who were going to do this for a year as my year of good work and giving back. And they didn't want to like open up and share everything and get involved with me, only to find that a year later, I'm going to go do my career somewhere else. And at the time, what I remember being obsessed by, and many is there was no career path to do this as your really full-time career. You could do it as a short-term thing, and then go and do your stuff. So we were trying hard to figure out how do you do that? And what they made us do was work in the team. So if I should leave, at least every homeless person on our team would know somebody else on our team. There wouldn't be a loss of continuity. And the last thing they asked us to do was respite care, which I will show you in just a moment. But what I didn't know is I went down the street from Mass General about 6 blocks, and this was where I went to my first shelter clinic. There were several shelter clinics I had to do. This is, at the time, an 800-bed shelter in Boston. It was the largest and oldest shelter in New England. And it had a really wonderful nurses clinic, which I didn't know about. But I remember walking into the lobby of this building, and it's sheer chaos. Everything is crazy. Noise was, it was deafening. And what my first impression was to share with you, I just finished my last rotation was the senior resident in the intensive care unit. And I remember walking, it was $6 down the street, and I'm in a shelter. And I'll never forget thinking, I was full of myself because I just finished residency and all that. And I thought they'd be thrilled to have a doctor. And I thought this would be a piece of cake. It's a shelter clinic, right? And I walked in and it was completely out of control. And I had no control over anything. And it was the first time I realized that in the ICU, I had all these dials I could control things with, but nothing out here. So it was a shock. And then I also ran into this nurses clinic that had been going for 15 years. I don't know if any nurses are here or not, but the nurses had figured this out long before we had figured it out. And they were hosting this little clinic inside the shelter every night. And I came in, and the brilliance of the nurses is they invited people in to soak their feet, as you can see this man is doing. And this was the cover of the American Journal of Nurses, actually a couple months after I started there. They were the only independent nurses clinic in the country. And the nurses were ferocious, fabulous, and they basically taught us everything to do. And I could spend a lot of time telling you that I, for 2 months, could do nothing but soak feet. They took away my stethoscope, told me I had been taught all wrong, said that unless you learn to get to know people, to settle, to be consistent, they're never going to trust you and you'll never get anything done. And I had come out of the world that many of us will share, where, you've got to be productive. You've got 15 minutes, maybe a half an hour, and you've got to make sure you get to know someone, get their chief complaint, examine them, make a diagnosis, and then move on to the next person. That doesn't work in homeless medicine, as I learned from the nurses. The next thing I had to learn was, with a whole bunch of humbling things. This is an X-ray of a man who I had examined at the shelter in the summer of '85, who I had seen 2 nights before and said he was fine, right? He had a chronic cough, no fever, no vital sign changes. On exam, I couldn't hear anything that was, remember, the shelter can be a little noisy, so you don't hear the subtle things. And as I learned later on, if I had done whispered ventriloquy, I might have picked this up, but I had not done that. But this was the first case we knew of tuberculosis. It was pulmonary tuberculosis. This man had probably been living in that 800-bed shelter for months with this. It was now kind of chronic. He had, as you can see, he's lost air. If you really look carefully, he's a right apical pneumothorax. And he became the first case of what turned out to be 60 cases of active pulmonary tuberculosis in that shelter that I showed you. And it was INH and strep resistant. So it was one of the first multi-drug resistant organisms we had seen. And everybody needed 4 medications every day for 18 months to be cared for. And that was my lesson was, first of all, I missed it. okay, that I didn't pick up that this man had TB. And I would swear to you, if you had examined him, you would have done the same thing I did. So we had to learn that just like in medical school, we learned TB can be all sorts of things. You got to be suspicious for it. And the second thing I learned is that I was good at one-to-one medicine, but I was terrible at public health medicine. And how do you take care of 60 people, all of whom are scattered all over the place? And I learned a ton from both the nurses and from them realizing we needed the hospitals, we needed the community, we needed everybody to sort of treat this. And so this was, I showed this because this is, for those of you who didn't live in this era, we didn't have digitalized anything. We didn't have computers. These were x-rays. So that's Barbara McInnis, who is the TB nurse at Pine Street, with Yoshiko, who's a nurse practitioner on my team. And that was sitting in Barbara's office with gazillions of these x-rays, each of which weighed about 6 pounds, by the way. It was really another time. But what we had to do, and this is when I think of, we were basically doing clinics in all the shelters, but we realized to get to the TB folks, most of whom didn't come back to the shelter because they got sick in the shelter and they wanted to stay outside. So remember, this is the fall of 1986. We were finishing up the treatment on this man who never came back to the shelter, but he was one of many, and we'd have to get on our bikes and go find them and give them their medicine every day and divide up that duty. And I was telling folks in our earlier meeting that the joy for me was everybody pitched in, and I learned that this is kind of fun when everybody's working together as opposed to when you're alone. And I had been a bartender for many years, and I had a friend who was a bartender down the street at a place called J.J. Foley's. And 7 of the men, by the way, this outbreak was all men. Nobody was immunocompromised. And 7 of the men would stop at this bar and drink before they came to the shelter. We have wet shelters in Boston, so you can come in drunk, but you can't drink or do drugs once you're in there. So they would get ready to be able to go get into the shelter and spend the night. So for 18 months, he and his fellow bartenders made them take their pills before they would pour their beer. And there was a barber in South Boston who did the same thing for 4 men. Before they had their coffee in the morning, he made them take it. So we managed with the whole village to figure out how to take care of this. And I was mentioning earlier that is now illegal, but it was kind of fun and effective back then. And I still think we need to be creative sometimes. But that's Mark, the social worker that was on my team, standing up with Ursula, TB outreach nurse. And that was the last day of the 18th month. The other thing we had to do, remember, this is all me learning. I know nothing about this, but the homeless people, that third thing they asked for was respite care. And what they meant then is they were angry with all of us in the healthcare system, especially doctors, because we would discharge people from the hospital when they were way too sick to have to walk the streets all day long. Most people would go home and, have a family and visiting nurse and home health aide and the supports of that. But homeless people didn't have that. So our folks insisted that we come up with a place where they can go and have 24-hour nursing and doctor care while they recover from something. So Governor Dukakis gave us 25 beds in the shelter that was a public health shelter. And we opened up this respite program. The word respite, by the way, came from homeless people, not from us, because it gets confusing. But we took care of people coming out of the hospital. And at first it was sort of cool, but we thought it was, in those days you could stay in the hospital a long period of time. I would just share with you, when I was a senior resident at Mass General, if you had a cabbage, which was becoming more and more frequent, your average length of stay in the hospital was 5 to 6 weeks. Okay, think of that. And if you had a hernia surgery, that was a week in the hospital. Gallbladders were usually 10 days in the hospital. Chemotherapy, we admitted you for your infusion and kept you there until you were okay to leave. And all of that now, basically, cardiac surgery is about 3.6 days, and the rest is all done as outpatients. And homeless people were kind of the unintended bad consequence of that. They have no place to go. How do you do day surgery if you're living on the streets? It's almost impossible unless you have a place like a respite program. And we opened that in September. And in the first week in October, this man came in. He has renal failure. He's on ambulatory peritoneal dialysis. So the hospitals weren't going to keep him. And he came in, and he was the first homeless person in Boston to be diagnosed with AIDS. And so we were just at the the opening salvo of what became a terrible epidemic, and affected homeless people disproportionately, as you can imagine. And they had really no place to be. And so we ended up having our little respite program being essentially an AIDS respite program for people that were suffering from these opportunistic infections. And in those days, we had no treatment for AIDS. Everybody who got it, essentially, we didn't know there were some that snuck through as non-progressors, et cetera, but almost everybody died, but it took them a year or 2 or 3 to die. And it was horrible. And I can remember being more discouraged than I can remember. I'm going to leave that alone. And there was I threw this in there because when I was talking before, but this was in, September it was Labor Day of 1901. And there was this, if you can see this at the top of the fold of New York Times, this shift in feelings on the homeless. Notice they use the homeless as a noun there, which we can't do anymore. But empathy turns into frustration. And what we learned back there, because everybody was dying and all sorts of things have been tried, there was a huge compassion fatigue, as it was called. I don't know if you noticed, the writer for that is Isabel Wilkerson. She used to be the New York Times homeless beat reporter, and she now has written these amazing books, if you have read any of her books. But I always worry that this is such a difficult problem and so complicated that people kind of burn out on thinking about how to do it or take care of it or solve it or something like that. And I urge you not to, as she does in this article, don't do that. So we moved from that respite program used to be in the shelter, and we moved it into this building in 2008, and now have about 104 beds of essentially looks like a step-down hospital. And it's kind of fun for us because it means if somebody's in the hospital and really doesn't need to be there anymore, we can bring them someplace where we can take care of them. The downside is it's only 104 beds. We could probably use 304 beds to satisfy the need. But, we can do things like people with frostbite. This man has frostbite at both feet. Is going to lose one of those. His left foot will auto amputate in several months, but they don't stay in the hospital. They have to go somewhere. So we've learned we have to do a lot of care for frostbite and post-hypothermia situations. And that's one of our nurses who is excellent at wound care. And then the other thing that, there are millions of things that happen there, like chemotherapy and, IV antibiotics and things like that. But one of the most important things we've learned is it's a place where people can go to die. Because end-of-life care for homeless people is really difficult. Okay. And I didn't show you this story, but the very first person I saw in the shelter who I talked to about, he had an esophageal cancer that was unresectable, was going to die within weeks. And I remember trying to get him into a nursing home or in a hospice unit. And I got him there. I remember being so proud of myself that I got him to a safe place, a place where he can die with some sort of dignity. And he left about 2 days later, because it was boring for him. He didn't know anybody there. As he read me the riot act, he said, people are staring out the window. They're not talking to me. They're looking at TVs. And he said, I've been at Pine Street with all my friends for 30 years. That's where I want to go to die. So he came back to the shelter because I had never thought to ask him what he wanted. I assumed I knew what would be best for him. So we ended up working hard to make sure we can keep people in some place where they know the staff and know other homeless people, and we can have them die. And these are just a quick story of two. This is a really interesting set of roommates who got to know each other. One's 80. This man is 84 years old, and he's dying of a neurological cancer. I'm going to tell you where he came from. And Byron, who's his roommate, has got lung cancer at the age of 37 that's metastatic to his brain. And both were going to be dead within about 6 months of this picture. But they became fast friends, even though one had grown up in the South working on a cotton farm. And Tommy, the one on the left, worked at a racetrack, the local racetrack. When you do this, you kind of always run into things you didn't know existed. And I lived in Boston for years. And we have a thing called Suffolk Downs Racetrack. It's a thoroughbred racetrack. It until recently raced from September through May. So raced through the wintertime. 1,500 thoroughbred stallions and horses and fillies stayed there, and they were cared for by these basically migrant and homeless workers who lived in the stables. And I didn't know anything about it until some guy came and said, you've got to come take care of these people. And he showed me the pageantry. This is Pat Day, the winningest jockey of all time, who was there that day. And this is where the horses lived, in these stables. I'm sorry about the bad quality of this old picture now. But what you can't see is those are horses staring at me, wondering why I'm taking a picture. But then right across from that is another stable where the the workers live. They live literally in the old stables. And they have a whole, they work really hard. They work, 6 days a week, usually 18 hours a day for money under the table. They usually send half of the money that they get back home to their families in Central and South America and get no benefits whatsoever. And when we started to care for them, we realized they won't leave to come to an appointment because they'll lose their whole day's wages. And in many cases, they lose their job because the host owner is going to get somebody else to do that job. So we do a clinic there, and that's where we ran into Tommy. This is him when he was feeling much, this is probably 20 years before that or something. And he's with a horse owner and he's taking care of the horses. He had been on the racetrack. He had lived from the time he was 12 or 13 years old, never got off the racetrack, can't read or write, but he knows everything about horses and he's really valuable there. And when he got this, this is, you sort of get the flavor. It's actually really fun there. And this is our nurse. We have did until the clinic closed down recently, until the racetrack closed down. We had to set up a clinic out there at the racetrack and realize that we have to go to them. Even when they're working, you have to go to them. This is Trish, who's our nurse, going to see some man who had been complaining of real sore throat, but he wouldn't stop work. I learned something from this picture, by the way, though, I don't know if you're horse people or not, but I was thinking, why the goat? And it turns out when you have these high-strung stallions in particular, if you put a goat in the stable with them, they calm right down. So goats are incredibly valuable on the racetrack. I don't have any idea whether that has anything to do with goat yoga, but we'll see. Anyway, and so what we would do with Tommy as he was dying, his only request was, could he go once in a while to see his friends at the racetrack? So we'd put him in, in our van, and that's Byron, his roommate, wheeling him, and he'd come to see the horses and just be back where he wanted to be. And it was just kind of delightful to watch this, even though it was sad that he was dying. And when he got out of the van, what would happen is all of the horses would go crazy, because he was the man that had taken care of them for so long, and they just were thrilled to see him. And the last picture I have him here is this picture of this horse sort of kissing. This is about, I'm guessing, 2 weeks before he would die, but he was smiling. That's really where he wanted to be. So learning what people wanted was a lesson we learned the hard way. Now, frame shifting is, we also learned early on that while we were so proud of ourselves, we had these clinics going on in all the shelters, and we had these 2 hospital-based clinics, and we were trying to make it an integrated care system. But that first winter, the people who died were the people who were living outside and didn't even come into our clinic. So we were not doing a good job of getting to them. And it turns out in Boston, about 95 or 96% of everybody will be in a shelter tonight. The very small percentage of people will be outside, even though there is a place for them if they want it in the shelter. And that population is the one that we've gotten to know, but on our team, we've sort of concentrated on. But the state, in response to the deaths on the street, the State Department of Public Health gave money to have a van. This is the van that goes out every night from 9 at night till 5 in the morning, to reach out to those people who don't come into the shelters. And I tried to make it a medical van in the early discussions back in 1986, because I thought it was natural for us to have doctors and nurses. But the homeless people themselves said no, they didn't want us. They wanted soup and sandwiches and blankets and things that would be helpful and useful in the middle of the night. So this is the real heroes in the story. These are the folks that are paid to do the van. They are from all different walks of life. Many have been homeless at some point themselves. Many are in recovery. And the key thing about them is, one, they're fun, and they know how to have fun in the middle of tragedy. And they never judge anybody, never judge a soul. So they've been really, I've been riding on this van for 2 nights a week, sometimes with Margaret and Sanjay, for years, until COVID changed things a little bit. But this is what happened. This is a night when it's -10 in Boston. It's a northeaster. There was going to be about 10 more inches of snow coming, and there was still like 100 people sleeping outside. This is a Steps of Trinity Church. It's a 92-year-old lady who stayed in this. It's the entryway to the old Boston City Hall. She would not move. We spent all winter trying to get her to come in. And you can see that her legs are getting red, and she's now beginning to get infections. We finally had to bring her in against her will, but it felt terrible doing that. And then this is Greg, who sort of illustrated for us a lot of what we had to understand. This is a picture he asked me to take, by the way. I'll tell you about pictures before because I never took pictures until somebody kind of twisted our arm. But this is a picture he wanted to take because he used to ask for money outside Fenway Park. And for those of you who know Boston, this is the famed Citgo sign right outside of Fenway Park. He even has even though I got to get this out of that mode, but I don't know how to do that. But he has a cigarette that he's holding. He doesn't smoke, but he thought it was cool for his picture. So that's the picture he got. And I met Greg when he lived up under these, we see where these are ramps going down to Surrey Drive in Boston. That's looking across the Charles River toward MIT. And those I-beams support about 40 people living up in there. And you can't see him. And that's where he lived when he was 15, living there with his mother and his sister. And we would go in the van. I think you can see it a little better on the next slide. You can see, get flavor for it, see their I-beams, and they put boards across the bottom, and then they crawl up and live in there. And they're out of sight of everybody. I drove by that all the time, never knew there were people living up there. And then that's the van folks bringing them sandwiches and soup. But we finally convinced Greg he got sick one day and he came over in the old days, to our McInnis House, and that's him coming in. That's one of our nurses. And he had, at the time, he ended up getting lymphoma, which we ended up having to treat, which is a whole long story. But it took us forever to get him to come from under the bridge, to trust us enough to come over. And then he's asked me when he came in if we could call his sister. He had one sister who was housed in Roxbury. And so I gave him the phone. I said, sure. And this is back before cell phones. And I gave him the phone and realized to some horror that he looked back at me and he could not read. He couldn't read numbers. He couldn't read letters. And he'd been living out under a bridge from the time he was 15 years old, probably earlier. I just knew it from 15. And it turns out it was an insight for us that about 25% of the men, I don't know the percentage, same percent of women who live on the streets of Boston cannot read or write. And so you know that whatever is behind them being on the streets chronically goes way back. And the solutions to it become very, very tricky and very complicated. So Greg, it turned out, couldn't read or write. When we finally had a chance to do some testing on him, his IQ was just less than 50. And he had never received any services whatsoever. And he was a Black kid in Boston who's kind of big and has a terrible stutter. So when people would make fun of him stuttering, he would start fighting. And then he was labeled just a troublemaker. And when you realize what was going on behind all this, it became kind of, like unbelievably awful. So this is Greg now, frame shifted about 20 years after that picture. And he now has lung cancer and is going to die of a bleed in his head about 2 weeks after I took that picture. But he's with his really close friend, Billy. And Billy was one of those people that I used to think was just a pain in the neck. He just was always insolent when you try, and I try hard to get him to accept things. And eventually he would start to say hello to me and say, okay, and he wouldn't be as angry. But as I got to know him more and more, he has diabetes, he's got AIDS, and now he's had a stroke. And he also, like Greg, can't read or write. And what I didn't know until this is till almost 10 years after I knew Billy, is that he had all these scars and he would never take off his shirt or his coat, but from his neck down, he's completely scarred. And when he was 5 years old in 1968, there were riots in Boston after the assassination of Martin Luther King. And somebody had poured gas all over him and set him on fire. And he had been almost 2 years at the Shriners Hospital getting, multiple surgeries and everything. And he, could barely move most of his arms and shoulders because of the skin tightness there. But I started to realize that's why this kid is so angry. He's just never had a chance. And he never had a chance to learn to read or write, even though he'd been in and out of hospitals. So the two of them became close friends living under a bridge. And most people thought of them as a pain in the neck, as did we. But when you got behind the story, you started to realize a whole lot more. Both of those guys, by the way, died within about a month of that picture. So what we ended up realizing was we were out at nighttime and realized that you can do a lot at night, but mostly everything is closed. So if we wanted to really do much more comprehensive care, we had to get out during the day. And so our team started doing this. This is our Jill, who's our physician assistant back then, and Cheryl, our nurse, sort of doing day rounds. And this man's about to go into detox. And we learned that if somebody says, I want detox, you have to have detox right away, because if you have any delays. So we had to set up all these fast tracking to get people in, and it would work as long as they trusted us. We would see a lot of people in the subways. And then we learned something to share with you guys that I also learned the hard way, is our nurses pushed us a little bit to say, what we doctors, what's so sacred about being in an exam room all the time and making people come to us? What can we do if we go to them? And, we thought, well, we need the privacy, you need the instrument, you need all that stuff of an exam room. And they pushed us a little bit. And it turns out if you look really hard, I challenge you guys to think this through. There's about 80% of everything we do in our exam rooms you could do at a McDonald's or a park bench. And so we started to think, for people that aren't coming into us, what can we do out there? And so instead of looking at it as first aid and episodic care, what can we do? So this is Dave Munson, who's the doctor on our street team now, one of the doctors on a street team with me now, who, much to my chagrin, is half my age, and unbelievably good. He went to Tufts Medical School and then trained at MGH, for those of you who might know that. And this is a woman who has terrible heart failure. She's 82 years old. And she won't come to the hospital. She won't come until the ambulance brings her when she can't breathe. So, and this is the train station called at Amtrak train station at South Station. But she's perfectly okay letting us do whatever we need to do there at the train station. So this is Dave. We can weigh her, we can listen to her lungs, listen to her heart, we can draw her bloods, we can change her medications. And she's perfectly okay with us doing it there. And she doesn't care about the lack of privacy, because you can do most of this without really. And so we managed her heart failure there for almost 10 years. With only a couple of episodes of pulmonary edema where she had to go in. And we would do it by keeping in touch with the heart failure clinic at MGH, where we'd do stuff and then say, what do we do now? And they'd say, here's what you do. So we realized this kind of, seeing yourself as part of a larger system and having access to all of that really affords a chance for people to get pretty good care. She ended up in a nursing home a few years after that, though. And then this was the other thing. This is Jim Bonner, who's our psychiatrist, and Mass General gave us the money to have a full-time psychiatrist on our street team. So remember, I told you we share in the care of everybody. So there's about 4 or 5 of us back then, and we took care of the people living on the street. We saw them as our panel of patients. So Jim came on so we could have a psychiatrist who was with us all the time, full-time. Which sounded luxurious at first, but then we realized it was not enough. But Jim, who he'd been a seasoned psychiatrist, he'd worked all over the country and ran community mental health centers, came out on the streets with us and realized that all these people that he used to think of as treatment resistant were not always resistant to treatment. They were just resistant to the systems we have. And anything that says psychiatry or mental health, they don't want to go to. Okay. But if you talk to them, in this case, this is at a woman named Katie, who he saw for almost 10 years. All of his therapy, all of his medications, everything went on right here. I want to say it's McDonald's, but it's not. It's whatever. It's one of the other things, but it's a place downtown. And that's what she much preferred. And we used to think of her as completely resistant to care. She would do it all there. So as you can hear me getting at, it's all about relationships and trying to figure out how to get to people. And I think they might be teaching us as a system a whole lot more about what we should be doing at the mainstream places. And then finally, just a quick note on COVID, because that drove us crazy. I'm sure it drove you all crazy. 40% of everybody living in shelters in Boston got COVID. It was a total nightmare because we couldn't isolate. To isolate somebody who's living in a shelter means you've got to have a place. There was no place. And so we had to set up tents, and we did a whole bunch of stuff. But when the vaccines came out, it was a little bit like a miracle for us because it had been so devastating so when the vaccines came up, but then we were worried about, will people take it? And here's the remarkable part for me. This is Jen Nunes, who's our physician assistant. And this is a park right near Mass General where homeless people gather. And I don't think anyone who's outside, save maybe 1 or 2, said no to a vaccine, even though I couldn't get people in other clinics to say yes to a vaccine. And it turned out it was because they were getting a vaccine. You can see Jen's giving the vaccine she's bringing around, but it's somebody they know giving them the vaccine in a place where they feel comfortable. And then they say yes. If we had said, go to CVS and get your vaccine, they wouldn't do it. So there's a lot of return on investment of there's a lot of return on the investment of time, I believe. And I think quality often is linked to continuity of care. The other lesson, and I want to stop so you can ask questions here in a minute. The other lesson we learned is that you can't do this, much the way partners in health learned that you can't really do this, find all this really complicated medical and psychiatric and substance use stuff unless you have access to the mainstream healthcare system. So our clinic for the street folks is at Mass General because that's geographically where most of the street folks are. And it's a clinic that we had to design specifically for people coming off the street. So you didn't want them to be stigmatized because they haven't showered, they look awful. So the hospitals gives us a separate waiting room. We now have our own separate clinic space. And we have coffee and donuts, and you make it really enticing for people to come in. First, we didn't think anyone would come, and it turns out, just like you could imagine, they come in if they know who you are. If you say, come see us in the clinic, they come. If you say, go to Mass General, they don't care. So this is our nurse doing vital signs and a man who lives under a bridge. And even though you can't really see it here, there is a guy sleeping under the table. I don't know if one of the medical students showed me, who is a graduate of Bowdoin, by the way, and was on the hockey team. And it's just it turns out that it becomes like a community gathering time, so that the clinic at MGH turns out to be one of the most fun things of the week. This is one of our patients on Valentine's Day, bringing our nurses and nurse practitioners flowers. And, it's just a place we can have residents and students, and it just turns out to be a lot of fun. And I'm trying to think of how to do this with time. 12:40. So give me 5 more minutes and I'll stop, and then we'll do 15 minutes of questions. Is that okay? Or if I'm boring you, we can stop right now and ask questions. But this is a picture taken by a patient of ours whose name is Keisha, who's now on a board of directors. And it was taken way back at the turn of the century. And it was a picture she took of her street friends. She did it with a throwaway camera. And those are all her real community. And there is one woman there who's hiding behind the man in the stripe thing. So she took that picture. I didn't see it till 5 years later when she was going in for surgery and she asked me to hang on to her stuff. But when I looked at this picture 5 years after it was taken, so this is 2004 or 5 that I looked at it, there was only one person still alive. Okay. And I was struck by it. It was the first time I just sort of visually had oh my God, this is a pretty significant disparity. And in this picture, the men, we knew them all. Their average age is in the late 30s. And they all have insurance. So this is Boston in 2000. Everybody had Medicaid who was homeless. And this is on the grounds of Mass General Hospital. So you can make the argument, here's a highly insured population. Medicaid in Massachusetts, by the way, is one of the better insurance plans you can have. And they're on the grounds of a pretty good hospital, yet no one's alive 5 years later. So that, as we've done more, I don't know if I have a thing, we've done lots of little studies now about, I think that's it. So if you look at mortality rates among homeless people in Boston, if you live in a shelter, you die 4 times the rate of someone the same age who has a home. If you live on the streets, it's 12 times. So the premature mortality rates among homeless people in Boston, anyway, I think in several other cities have shown that, look very much like some of the most remote third world countries, yet they live in the shadows of our great institutions. One example here, this is a basal cell carcinoma on a man who was in that picture, who I got to know. He's a delightful guy. He had schizophrenia, and I get basal cell carcinomas all the time. So I said, we can fix that, no problem. This is 15 years before the picture was taken, but he insisted he could take care of it. He could pick it or do whatever. And then finally he said to me, okay, I'm ready. He took his hat off. And this is a basal cell. It's a terrible picture with this lighting, but suffice it to say, the redness under that is a basal cell that has basically encapsulated his skull. And so he had to have major surgery with flaps. And we did that. And this is him 6 months after that picture was taken. He's had all the surgery. We got him in a place to be at home, and we're visiting him at home as he's undergoing his thing. And what happened is his basal cell became metastatic to his spine, and he died of metastatic basal cell carcinoma. Still the only patient I've ever had to die of that. Utterly preventable, but the challenge of doing that was beyond. And then just to end with how, I guess let me skip over this. I'm going to skip over this and tell you what we ended up having to do. So let me end on this. So what we've learned is people die outside and they die in the shelters. So why don't we get them housed? We got to get them housed, and then maybe we have a chance. And so this is the woman who is the vice chair of our board of directors. She lived in the shelters for years and on the streets. She started the National Coalition for the Homeless's National CAB, Consumer Advisory Board. And when we ended up starting to get people into housing, the people who had been on the streets for years became eligible for these low threshold housing programs. And we were thrilled. We celebrated. And they went into housing, and she called us in and said, look, if you've been our doctors and nurses for 20 years, you can't stop caring for us once we go into housing. That's abandoning us. So she put us to the thing. And so we ended up doing a lot of home visits. And this is one of the first people we got in, just to show you how we celebrated. This is a man named Jose. He's just fabulous. This is a team of, combined of housing workers and our team. And he's at our McInnis House celebrating his 60th birthday. And this is where he lived, in a covel with 8 of his friends. It was on the Amtrak line. And I don't know if you can appreciate it. It's a tent there and it's a mess, but this is the junk around it, because it was in land that wasn't technically Boston, not technically the state. And so it was just a mess. And they lived, you can see the tent up there. And the way they did it was they would have 2 people sleep at a time on this mattress inside that hovel, and then they'd leave and 2 more people. So they could actually sleep 8 people in this little thing, which I thought was kind of Marine style. This was their bathroom. It was just disgusting. And he had been conscripted. Grew up in El Salvador, and he was conscripted into the army to fight in the war. And he tried to desert when he was, I think, 14. And they macheted and broke his fingers. And now this is a night where we saw him, and he had gotten frostbite over the broken fingers. It was really just tragic. But anyway, he gets into housing. He's one of the first people, and it was like a miracle. There he is with one of the other people's name is Marcos, and they are so proud to be in their housing. And they both had been sort of sous chefs, or, maybe short order cooks. And when you go in, this is their living room. This was an unannounced visit. We were just doing home. And this is their dining room table, the doily and flowers. And the kitchen is immaculate. This is a kitchen, and there's soup in each of those 2 things there. And they make you sit down and have soup with them. That was part of the deal. So we thought, this is it. We have figured it all out. And I remember now we were doing, like that's Jill doing all our primary care visits you could do right at home, do the vaccines at home. And we, as a team, started to do more and more house calls. So what you can see within about 5 years, we were doing over 1,000 home visits to street people after years. But it got more complicated. And that's what I'll end with. We realized that when you get people across the threshold of a home, which is absolute key to ending homelessness, it doesn't end the whole problem for many of these people who've been struggling for years with problems. So your major problems, whether medical, psychiatric, or substance use, don't go away just because you go into a house. You have to do a lot of support. And this is one example. These are 2 men who were found hypothermic, both had body temperatures of less than 70 degrees, the only 2 I've ever seen, who then survived it. And they survived because they got quickly to the emergency room at MGH, and they brought them up to the cardiac suite and put them on cardiopulmonary bypass. And that's how they did it. But anyway, this is where they were, right near where the Celtics play. They were found in a dumpster there on a very cold January day. And then this is John, the guy who's standing in his home now. After we got him through that, he's in his home, almost no perceptible neurological damage from what went on. And that's his housing worker, who is wonderful. And we would visit him at home and take care of him, but he's got early cirrhosis, And so over the course of about 2 years, as he just does really well, and then he looks like this. And he still won't come to our clinic. We have to go do all of his care at home. And you start to realize that, people that end up outside have they want to do things their own way, and our system doesn't always accommodate that. So we realized that our work had just begun when they got into housing, not ended. And last thing that I would just share with you is we also ran into this is Donna, who we love, was a victim of awful domestic violence. She came into the clinic one day and ended up putting, through a whole lot of things, the person who had beaten her up was now in jail. And she got sober after that and did really well. She became actually the first patient we had who drove her car. She had a car. So it was the first time I ever stamped a parking thing for somebody in our clinic. But here she is, and she got a job at a laundromat, really delightful. And we would visit her at home. This is her boyfriend, a new boyfriend, who she really took care of. He was having lots of struggles, but she was a caregiver for that. And then that was an apartment that they were paying whatever it was, $1,200 a month to have. And the apartment then went, let me get back. So she came in one day and had a right arm that she could barely move. And after a bunch of trying to figure out what was going on, we thought it was orthopedic. It turned out it was lung cancer in her right upper lobe that was affecting all of her nerves. So she presented with stage 4 lung cancer and went through chemotherapy, radiation, was doing okay, but then it came back. And right when it came back, she was evicted from her apartment because the apartment went condo, and she had the option of spending $262,000 to buy it, or she had to leave. And she's right at end stage. I remember the last picture I have of her is she's back on the streets. That's her boyfriend with her on her wheelchair. She's just finished a round of palliative chemotherapy at Mass General, and she's back at that park with all her homeless friends. And she actually ended up dying the day after this picture, bleeding out. Something had eroded into one of her pulmonary vessels, and she bled out. So the story, what I would share with you, this is complicated. And I think the name of the game is you have to stick with people. And so whatever systems we can do that provides some continuity, which is hard and takes time, is really what makes a difference, I think, in the long run. I think that's it. I think I can stop right there because I want to be sure we have time for questions. But anyway, so thank you. We can talk more and more, but if you have any questions, I'd love to hear them.
Yeah.
It's like I dare you to ask a question, right? Yes, I'm sorry.
No, just.
I was wondering what percentage of the people out there on the street are actually mentally ill? I've heard different figures on that.
It's a great question, and we talk about this all the time. So one thing to keep in mind is if you look at, they've done these studies now, which I'm kind of surprised at. If you look at everybody who's homeless during the course of like 10 years coming in and out of the shelters, most of those people, the vast majority, 80%, are people that are only there for an emergency situation and leave. And among that group, there's very little mental illness. But if you look at the people that are chronically in the shelters and on the streets, which are 10 or 20% of the total, among that group, you can see anywhere from 30 to 70% of them have mental illness. So we tend to think of all homelessness as what you see on the streets, which is not a good way to go. So when you say of our people on the street, 70%. So it's really, and what I would say is even worse, 70% of the people on the street have co-occurring medical, psychiatric, and substance use disorders. So it's a very complicated, complex care situation. But that's not all homeless people. That's those who have been a year or more out on the streets and in the shelters. Is that answer? Okay. Yes, Donna, sorry. Oh, I'm sorry.
Thank you for this. This totally brings me back to my public health NIC days when I was doing work with, we talked before, needle exchange programs and the homeless outreach program in New York City with the mental health piece of it. I was curious that your program is able to give out treatment and medications outside of a clinical setting, because we were not in either of those programs able to do that. And is that because it's part of a comprehensive healthcare system to begin with? That's where it comes from? Or because we talked about trying to bring medications or bring something to the folks who are under the bridges and, as part of the outreach connection, trying to, bring them into the clinical setting. But that wasn't something we could do. I just was curious about that.
It's a great question, and I'm a little awkwardly answering it. When we first started back in 1985, we had a grant, so we weren't involved with Medicaid or federal money or anything. It was just fun, but we were all licensed. One of the requirements was we had to stay part of the hospital. So I've always had to have been a Mass General doctor, so I can do whatever I do at Mass General, I can do outside. which is how it looked at in Massachusetts. So as long as we were credentialed in the hospital, we could do anything. The bigger issue became when we became, when the grant ended, we're now part of what's known as a federally qualified health center, which is like a good news, bad news kind of thing. But federally qualified health centers bill Medicaid, and then you've got all the rules. So what we learned is that with healthcare for the homeless programs, it was a waiver to be able to do this outside. And now, believe it or not, there is a street medicine code or street code. If you see somebody on the street now, you can bill Medicaid all over the country with a CMS code now, which is, can't remember what it is, but you can bill. It's a legitimate, you don't have to be in a licensed medical clinic anymore for that. So that's been a huge change over the last few years.
Yeah, that's awesome. Thank you.
Well, thank you.
We'll do it this way. Question from our Zoom audience, and everybody is saying, thank you so much for your presentation. And this has to do with education and education of future clinicians. All of us train in great buildings like this and rarely get out into the community. Can you talk a little bit more about how current or prospective clinician students can get involved with work like this?
Yeah, and that's kind of a local question. So let me tell you what happens for us and then urge you to think of. So over time, now remember, I'm talking 40 years down the line. I'm not talking about yesterday. So we have 30 doctors in our program now working. And it took us 5 years to get a second doctor. So it's a process, right? But what we learned is as you can get students, nursing students and medical students and residents to come out and work with you, they get to see what the work is all about. It's great for us because we get to feel like we're teaching. And I would say of our 30 doctors, all but one of them rotated with us as students or residents. So for us, it's the most selfish thing we do. That's how we recruit. And you don't even have to worry about interviews. You know what somebody's like. So I think the opportunities for one, we need to set up programs like this and then make sure that's part of the curriculum. We now have, for example, the community psychiatry rotation, MGH, second year, all of the second year psychiatry residents spend time with us out on the streets as a requirement. And it's been great for us. That's where we recruit our psychiatrists. And then all of the primary care residents spend time with us. And a lot of the Harvard, that's how I got to know Margaret and Sanjay as when they were medical students, they came out with us. So that I think is such a great opportunity for all of us. Now, the problem is where are those settings in other cities? And that they're different everywhere. So you have to find out what those settings were. I was hearing about that wonderful clinic today that happens. Dr. Allen does. I saw Dr. Allen was here somewhere, but Dr. That sounds like it's a great opportunity here. I don't know what happens once you become a resident. I don't know what the opportunities are here, but I would urge everybody to think of that as a really great place to see unbelievably good stuff and learn stuff. We have a dental clinic I didn't talk about. So we have 8 chairs. We have 3 dentists. Took us forever to get that. But we get help. We have 6, the dental fellows from Harvard and BU spend 6-month rotations with us in that clinic. And it's become the most popular rotation in that thing. And I thought it was great. It's us, it's health, but it's not that. It's that they see stuff they would never see otherwise. And they love it because most homeless people have never seen a dentist and they have, their teeth is amazing. So that's what I think we get a chance to see, things that have, we don't get to see pneumonia neglected for a long time until you get outside and see what happens. So I'm huge on figuring out how to make this part of the educational system. Thank you for the question, by the way. Thank you.
Thank you very much for the really cool talk. My question was, how do you think the current and future upcoming political climate is going to affect the future of street medicine programs like the Boston program?
Ooh. I'm scared to death because I think the atmosphere right now, the prevailing atmosphere is they would just as soon get rid of all this. And we're laboring under that now. The executive order is a really targeted essentially most of the people we take care of. And we're being threatened currently with losing our money if we continue to do stuff like that. So it's kind of interesting, not interesting, it's kind of horrifying to think that what we were asked to go do is now seen by people as not right. So we can't do, we have to stop doing our gender. We have a huge transgender clinic because there was a ton of homeless people that needed that care because they couldn't fit into a shelter. We have, we've been trying hard to be as, as diverse and inclusive as we could. That's now all illegal. and it's called illegal. And we can't do immigrant care. We have an influx of immigrant families coming from the southern border. And so we do care for all of that. And they're threatening to take our money away if we continue to do that. And that when I say us, it's all of us collectively. So I don't know. It's just an awful environment right now. It's like nothing I've ever seen or dreamed of. So thank you for that awful question. I do not on that one.
Thank you for your talk. I'm actually a scientist, so not a clinician, but I'm interested. I was wondering, within the first 2 months that you mentioned, like when you joined this cause, what happened? So I'm more interested on the management side, beside being a clinician or of any type. How much work, what type of I guess, where did you look into that this has done before to have it be a successful effort as far as managing such an effort? It's a big undertaking to me to have the operations and everything, the legal side, and I guess many things.
Yeah, and we were talking last night, and I don't know if Sanjay asked the question of if we were to start up today, how would it be different? And I have to be honest, it would be really much harder to start up today than it was back then when we could ask a bartender to give medication, and I worry a lot about that because I think you're right. So what happened to me is when I came in traditionally trained, not having any idea what these obstacles to care were. And when I had to soak feet for 2 months, that was my apprenticeship, right? There was no one telling me I had to be more productive. That was my job. And there was a grant paying for me. I wasn't billing. But I realized that investment in 2 months of learning to slow down and figuring out how to get to know people resulted in a huge, I'm the first person I had to soak his feet was 25 years at MGH as considered treatment resistant in and out of the emergency room. In 2 months of soaking his feet, he started taking all the medicines we had spent 25 years trying to do. So I started to catch on to, for some populations, doing these extraordinary things is a great investment or foundation for then opening up care. But we don't do that very often. So if I started that now, we'd have to come get some independent money to pay for people to, bottom line, Medicare and Medicaid don't pay for foot soaks. And so time is what is needed for this population. And I think for many, excluded populations, but we don't value time. We don't value long time in the system. We value short periods of time. And I think I worry about that would be a big challenge, particularly to any administrator, anybody trying to start up. That would be the thing. I don't know if I'm getting to what you were concerned about. Is that kind of it? I think the other thing we wouldn't have been able to do what we do without the hospitals buying into it and the mayor buying into it. So we were lucky this grant went to the mayor who held the hospitals by the thing that you got to be part of this. And so we benefited from that. So if I were to start, I'd say, make sure you've got a community willing to recognizing this is a need in our community. Let's all get together and do it. Then all things become possible. But if you're trying to do it alone, you can do great work, but you can't expand into where you want to be. That's opinion of one person in Boston, by the way. You could hear other opinions. Okay. Yes.
Yes, the patients that you were seeing outside of the clinic, if they needed medications, how were they getting the medications?
Great question. So, what the truth is in now this is another local, all politics is local, all healthcare for homeless people is local. So that's not an issue for us. If I'm seeing someone, I can write a script and give it to them, Or I can call CVS or call the pharmacy, and we have our own pharmacy now, and just get the medicine and give it to them. So there's no financial barrier. There sometimes can be a geographic barrier. And if there's that, then we get the medicine and bring it right to them. We used to carry lots of medicine in our bag, but that turns out to be kind of illegal too, because you can't just give out medicine. So we had to like change, and now we do it by the book. So if you need penicillin tonight, I'll either write the script or I'll call in the order and we'll go pick it up and bring it to you. But there's no barrier in that sense. Okay. The biggest barrier for us is getting someone to take it. And that's what we do. Okay. Great question.
We are at time, so I want to, but thank you so much for what such a wonderful talk. It's a privilege to hear your stories. Thank you everyone for joining. And to quickly plug, we'll have a Medical Center Hour next Monday. Andrew Soren is coming to give a talk speaking up about meaningful work, navigating its power and pitfalls. So hope to see you then. Thank you, everyone.